I will introduce both of them so that I don't have to get back and forth twice. I know Lauren from medical school. She's almost a Sinai lifer. So she was here for medical school. Previous to that, she was at Princeton for her BA in psychology. After medical school here, she did an internal medicine residency, chief residency, and then she did a 2-year general internal medicine fellowship, and we're lucky to have her now as an attending. She's an assistant professor in the Department of Medicine in the Division of General Internal Medicine. She's also founding director and a current associate program director for the new primary care internal medicine residency program. Her teaching and research interests focus on primary care, communication, and collaborative care. She's a PI on an NEGEA Collaborative Foundation grant on communication during consults, and she actively teaches both medical students and residents. And her talk today and her presentation for Education Research Day was, does resident satisfaction with ambulatory continuity clinic influence career choice in general internal medicine? Lauren Stossel will be second. She is currently a 4th-year student at Sinai to graduate very shortly. She received her BA in Religious Studies from Wesleyan. She's part of the Humanities and Medicine program. She then was a policy analyst before she came to Sinai as a medical student. She received a clinical research fellowship from the Doris Duke Foundation and spent last year working on the project that she's going to talk about, which is the reliability of patient education materials, as well as patient navigation as an intervention to improve adherence to screening protocols in East Harlem.
So, good afternoon. The objectives of this talk and the project overall were to determine resident satisfaction with ambulatory continuity clinic, and specifically elements of ambulatory continuity clinic. And we did this in 3 residency programs. And to determine the relationship between internal medicine resident satisfaction with their continuity clinic and whether or not they choose careers in general internal medicine. So a little bit of background. As you all know, many of us in the room, I think, are primary care providers. There's a worsening shortage of primary care MDs. And sort of compounding that issue, the percent of trainees pursuing primary care fields, at least before maybe now, maybe things are on the uptick now, but before now, were declining. So in the 1990s, about 9% of medical students entered primary care, whereas in 2007, only 2%. And in 1998, in terms of internal medicine residents, about 50% entered general internal medicine. That's a huge number compared to what now is the case, which is, or at least in 2006, which is 20%. And as evidenced by our own internal medicine residency program, before we started our primary care program, the majority of residents were going into specialty fields. So the question has been asked before, mostly in surveys and qualitative analyses. Some things that have seemed to be associated with entering primary care is female gender, having had a good primary care role model, valuing social responsibility and altruism as part of your career goal, low financial motivation, which makes sense for all of us that work in primary care. We are not in it for the money. Or academic medicine, agreed, and potentially early exposure to ambulatory clinic. So a very interesting piece by Kearns in 2008 posed a question as to whether it was really the amount of ambulatory care that you got or whether it was the quality of that ambulatory care experience. And there really is very little literature out there looking at the quality of the ambulatory care experience and whether that influences whether people go into primary care. Just sort of as a side note, the amount of ambulatory care that residents, internal medicines are exposed to was increased. At some point, I want to say 10 years or so, maybe even less than that, 5 or 10 years ago, when it was decided that it had to be 1/3 of the residency program, you had to be in ambulatory care. So that happened in internal medicine. But it didn't seem to at least influence the amount of residents going into primary care, at least directly. Okay, so just again to reiterate the objectives, but more I want to talk about the hypothesis related to them. So we hypothesized that residents are not very satisfied with elements of clinic, at least certain ones. And maybe those elements that they're not satisfied with have some relationship to why they're not going into primary care. Okay, so we conducted a cross-sectional survey, and we chose 3 urban academic medical centers, although the third is maybe not quite so academic, but Temple University, Mount Sinai, and Bayview Johns Hopkins, which is more of a community medical center. The participants were all categorical and primary care residents, no preliminary residents. And depending on the institution, they were recruited via email or at conferences. The survey design was based on the VA Learners Perception Survey. I'm not sure if any of you have seen it. It's this huge survey that was designed by some VA faculty to look at satisfaction on the inpatient side. And there was an adaptation for the outpatient side that was done that was not validated. So we actually validated the outpatient survey. And what happened was they had sort of grouped them into domains, but when we revalidated it, some of the domains actually fell out a little differently. So we came up with 6 domains that I'll show you right now. So the 6 domains that we came up with for these clinic elements were clinical preceptors, so how satisfied with you are of your clinical preceptors, educational environment, ancillary staff, time management, administrative, so records keeping, paperwork, and personal experience, so sort of how is your relationship with your patients and your colleagues. The outcome measure that we looked at was the consideration of a GIM career. So this was the question that was asked. As a result of your continuity experience, how likely would you be to consider a future employment opportunity in general internal medicine? And then for the outcome, we dichotomized that into basically yes or no. And the predictors were demographic data, and then the 32 satisfaction items that were grouped into those 6 domains. And the other thing to note is that we dichotomized the satisfaction into very satisfied or not very satisfied. And you'll see why we did that. The main reason is that people were a lot more satisfied than we expected, so the results were skewed towards the satisfied. So in order to really get a good spectrum, we had to dichotomize at the higher level. I don't want to go into this too much, but we looked at it in a univariate way, just comparing each element with the outcome, and then we created a model in which we took one element from each domain and put it into our model to see if those were significant. Okay. So we had about a 91% response rate, which was really fantastic. And they were evenly distributed across gender, site, and PGY level. And just in general, about 48% were likely to enter GIM before clinic. That was different among the sites. As you might have guessed, Mount Sinai was the lowest among that number. And I think Bayview actually was the highest on that number. And then just the basic outcome data. So before clinic, about 48% were likely to consider GIM, and about 38% as a result. So it went down by about 10%. And you can see here, just on the bottom, we looked at the change. So this is not whether you went from likely to unlikely, but whether you went from very unlikely to unlikely. So just even a change up or down. So 11% were more likely, 27% were less likely, and about 60% were equally likely after clinic or as a result of clinic. Okay, so what I'm going to show you now is just general satisfaction within the domains. I don't want you to get too bogged down with the multiple different elements. The idea is that each domain kind of groups together. So you'll see that overall for preceptors, people were very satisfied. As you can see, the purple is very satisfied. The blue is somewhat satisfied. And I didn't even put the dissatisfied up there because it's just the little what's left on the top of the 100%. So in general, people were very satisfied with their preceptors. Educational environment still pretty satisfied, maybe a little less so. And the main one that was problematic was access to specialty clinics. And I can vouch for that being a general issue, which is really hard to get patients in to see, you know, ENT or ortho in any kind of a timely way. So I think that's where that is coming out. So ancillary staff, again, generally very satisfied, maybe a little less with the front desk. So time management, I think, is the biggest one to look at. It still looks pretty good, but some of them are about 50% satisfied. So that's where we start to see the breakdown in what is not enjoyable about the clinic. So you can see some of the things that I'm just going to highlight are the number of clinic patients seen and the time allotted to see patients. People are not too satisfied with that. And then ability to balance ward and clinic. That's another big issue out there, thinking about taking out clinic from the ward months. And a lot of institutions are doing that now. And then administrative is sort of along the same line, so amount of paperwork. Obviously, people don't like that. That's a big problem in primary care. And then personal experience is better again. So residents actually do feel reward and are satisfied with the relationships they have with patients. And surprisingly, they were relatively satisfied with the continuity of relationships that they had with patients, which was not what we expected. OK, so now I'm going to talk about the associations. I'm not going to show you every single one because it's a little bit overwhelming, but I wanted to give you highlights within each domain. So in terms of the preceptors, as you can see, there is a relationship between those who are very satisfied. It's a little bit confusing. So those who are very satisfied with the role modeling, of those who are very satisfied with the role modeling, more are considering GIM than those not considering GIM. So there's about a 16% difference there. And the same is true for mentorship. So the more satisfied you are with mentorship, the more likely you are to consider GIM. There was no significant difference for either of these two. And the reason why that P of 0.003 is not significant is because we had to do a correction because we're doing so many comparisons. But we ended up using that number in the clinical knowledge and skill number in our multivariate analysis because it was close. So ancillary staff, there were no differences. And this is another highlight. So in terms of, so again, people were not very satisfied with this in general, and the people who were more satisfied with the number of patients they see in clinic were more likely to consider GIM. This is kind of a confusing concept because we didn't actually know how many patients they were seeing in clinic. But the same is true for time allotted for patients, and we know that each patient is allotted about 20 minutes. So for residents who were satisfied with that 20 minutes, who felt like they could get the job done in 20 minutes, they were more likely to consider GIM as a career. Okay, and then there were no differences in administrative, paperwork, space for precepting. There were significant differences, though, very significant, in reward from work and continuity with patients. So this was something that we were hoping to see, and we did. So the more continuity, the more satisfied the residents were with continuity with patients, the more likely they were to consider a GIM career. OK, so this just repeats that. I'm not going to get into that. So this is our multivariate analysis. I didn't include every single thing. I just included the significant values. But as you can see, the things that remained significant were continuity of relationships with patients, enhancement of clinical knowledge and skills, and the number of clinic patients seen. So those elements were, if you were satisfied with those elements, you were more likely to consider a career in general internal medicine. The other thing that's really important to note is that considering employment in GIM before clinic was a very, very strong predictor of considering it after, which makes a lot of sense. But it's also important to think about when we're thinking about how we're going to change the workforce, and that we really have to catch people early before they come to residency. And then finally, what's interesting is that PGY3s are less likely to consider GIM, which I think also makes sense. As you go through, you get more unhappy with things and don't like them. So the non-significant predictors were preceptors as role models, medical assistant staff, and space for precepting with faculty. Okay. So the limitations of this study is that it's obviously just a cross-sectional design. We didn't do a real pre-post, and we didn't follow people's perceptions of their clinic experience over time. It was also only limited to elements of the clinic experience, not to other things like how inpatient experience influences whether or not you go into outpatient, or personal goals, and we didn't look at money and all those other things. It's also only self-reported satisfaction and self-reported career plans. So we didn't actually look at what people actually did after those 3 years. And we do have 3 institutions, so the program generalizability is better, but they're only on the East Coast, and they're all urban centers. So not everyone is really accounted for there. So the conclusions we made are that residents are actually satisfied with many of the elements of clinic, especially a lot of the educational components, the preceptors, the educational experience, the patient experience. But they're not satisfied with a lot of the paperwork and time management issues. And then we also found that their satisfaction with certain elements, including areas in time management, continuity, and knowledge and skills, seem to be associated with choosing a general internal medicine career. So what does this mean? It's really important to focus efforts in improving continuity of relationships with patients in clinic. And that's one of the things that we're really working on in our clinic, and a lot of clinics are working on in many locations. And also, time management training is really key. I think a lot of residents feel overwhelmed and feel like patients with multiple chronic comorbidities are really challenging to treat in a 20-minute visit. And how do they pick and choose which elements of those patients' problems to work on? And so I think that that's something really important to help residents with. And the other implication, too, is to get people to go into primary care, we have to get them before they're in residency. So I just want to thank my co-authors, Lawrence Ward, Sean Tackett, Alex Fetterman, Ira Hellenius, and David Thomas. And that's it. I think I maybe have like 3 minutes for questions. Thank you.
So I'm Lauren Stossel. I'm talking about the readability of patient education materials that are provided at the point of care. What I would love to do to start is if you guys would write down 3 sentences that describe how hypertension affects the body, and just hang on to them. I'll give you a minute to do that. Okay, someone's done, so I'll keep going. So I'm going to talk about the definition of health literacy, the prevalence of health literacy in America, and the consequences of low health literacy. Then I'm going to talk about how we use patient education materials in the hospital. Then I'm going to give you a little bit of information about the design and the results of my readability analysis study. And I'm going to talk about the limitations of the study as well as its significance and some directions for further research. So what is health literacy? The Institute of Medicine defines health literacy as the degree to which individuals can obtain, process, and understand basic health information to make appropriate health care decisions. It's considered to be the single best predictor of an individual's health status. So it outweighs age, income, employment status, education level, race, a lot of things that we think of as being predictors. It's really common to have low health literacy in America. So 77 million people in America have difficulty with common health tasks, things like following directions on a prescription label, adhering to a child's immunization schedule, things we think of as being basic. The average US resident reads at an 8th grade level. The average Medicare beneficiary actually reads at a 5th grade level. And this has a lot of consequences, both for individual patients and for our system as a whole. So these patients with low health literacy have increased rates of non-adherence. They have higher rates of health-related anxiety and depression. They have higher hospital admission rates and higher rapid readmission rates, which, as we know, is really important for reimbursement. And they have higher rates of mismanagement of their chronic diseases. On a systems level, low health literacy is estimated to add an additional $73 billion worth of burden to our healthcare system. So this is a big problem. There are lots of different ways that clinicians attempt to educate these patients. One way is through the use of patient education materials. So in one study, 70% of healthcare professionals reported routine use of handing out printed materials to patients. 73% feel that this is an effective communication technique. And a lot of studies have looked at the educational materials that are left as pamphlets in waiting rooms. Increasingly, these are actually being used at the point of care. So one way this is happening is through electronic health records. Obama's 2009 stimulus package set a goal that every individual in America would have an electronic health record by 2014. And the companies that produce electronic health records partner with companies that make patient education materials. Health literacy experts feel that this is actually really great because it means that instead of just leaving something in your waiting room for people to pick up on the way out, you can, without navigating away from your patient's chart, pull up information for them and use it as a teaching tool during your visit. So you'll have something that they can refer to, and then they can take it home with them. Institutions are tacitly endorsing certain patient education materials and certain patient education material providers based on which electronic health records they purchase. So it's really important to assess whether or not these materials are appropriate for educating our patients. The National Library of Medicine is another important source for this because it's online, it's free, it's accessible everywhere, and it's government accredited. So the aim of my study was to determine the readability of patient education materials that are supplied through the National Library of Medicine and the most popular electronic health records company. And we hypothesized that most patient education materials from these sources were going to be written above target readability. Target readability is defined by literacy experts as being at or below an 8th grade reading level. So this is how we selected our sample. We tried to choose patient education materials with high market penetrance that were also very accessible. So this is a report from Modern Healthcare that shows the top vendors of EHR systems. That's based on the number of installations in the US over a 1-year period. As you can see, Meditech is sort of the front runner. There were 27, it was installed at 27% of US institutions, which makes it the most popular. So Meditech's patient education material suppliers are Micromedex and EBSCO. EBSCO is the same as Lexicomp, which you've probably seen before. Lexicomp actually markets itself as being really appropriate for patients with low health literacy. They say that their documents are written at a 6th grade level. The National Library of Medicine gets its patient education materials from Medline Plus. Again, available to anyone with internet access. It receives more than 155 million annual visits. So we selected 100 random disease-matched patient education materials from each database for a total of 300 educational materials. That was based on a proportions calculation, assuming that half of the patient education materials we looked at were going to be above target readability and half would be below. And then we performed a readability analysis. So just to give you a sense of what this means, a readability index is a mathematical formula that assigns text a grade reading level. These were originally developed for schools, for textbooks, so that you weren't having a 1st grader be reading a textbook that was written for a 3rd grader or vice versa. Increasingly, though, these have been used for a lot of other readability analyses in different fields, including medicine, and we chose 3 that were endorsed by the Health Literacy Advisor as being appropriate for looking at consent forms and patient education materials. So these are the indices. It just shows you the formula. Basically, they take into account the number of words per sentence and the number of syllables per word, or complex words. Flesch-Kincaid, Gunning-Fogg, and the simplified measure of gobbledygook, or SMOG, were the three that we used. They all have advantages and disadvantages. The disadvantage that was important for our study was that Flesch-Kincaid actually underestimates the grade reading level by about 1 to 3 grade levels. And you'll see when I get to the results why that was sort of important. And these were all recommended for patient education material analysis. So we selected the patient education materials to use by a random numbers generating program, and we tried to favor common topics. So if one of the numbers corresponded to a disease topic that was sort of obscure and it was only found in one database and not in all three, it was excluded from the analysis. Some of the databases, especially Medline Plus, offers easy-to-read patient education materials for some topics. So if you search hypertension, you might get a bunch of possible things to look at, and one of them will say easy to read. So when that was available, we preferentially included those. We cleaned the patient education materials before we put them into the calculator. That basically just means that we made sure that there was a period at the end of every sentence so that the calculator was able to assess them accurately. And then we recorded the percentage of the documents that were written above target readability. We also looked at the median graded reading levels, and we used an analysis of variance to compare those between the databases. And this is what we found. So this chart is a little bit confusing. You can see here, these are the three databases that we looked at. For each one, we did an analysis using the three different readability indices. And then here you can see the percentage of patient education materials that were above target readability, the median grade reading levels, and the range from low to high of grade reading levels that were available at each database. So Micromedics did the best. Its averages were somewhere around target readability, which was good. And that's why you can see that the Flesch-Kincaid, because it skews a little bit lower, was actually showing that only 31% of these were above target readability. But when you look across the rest of this column, anywhere from about 60 to 100% of these documents were written above an 8th grade level. And when you look at the averages and the ranges, you can see that some of them were written at 11th, 12th, 13th, 14th grade levels. Medline Plus's highest, like most difficult educational material was written at a 17th grade level. That's like the New York Times. If you plug in a passage of the New York Times to one of these calculators, it's about 17th grade level. So what we saw was that the patient education materials that are available through the National Library of Medicine and Meditech, this very popular electronic health record company, are really written well above target readability. And we also found that Micromedics' documents were significantly more readable than the other two. So does anybody want to read what they wrote about hypertension? Does anyone think they wrote something that's really simple or really technical? I saw 5 people writing, so someone has to read it. Thanks, Lauren.
It makes the heart work harder, the blood vessels get hardened, and your kidneys are damaged.
Awesome. Did anyone write something that was a lot more technical than that? These are primary care people. This is great. So you guys are really good at this, and other people are really bad at this. So here are some of the examples from some of the patient education materials that were really complicated. EBSCO on hearing loss wrote, surgery may be done in some cases of conductive hearing loss to correct the middle ear problem, such as in otosclerosis, ossicular damage or fixation, and ear infections. Micromedics on female infertility wrote, clomiphene citrate. This medicine causes the pituitary gland to release more hormones such as follicle-stimulating hormone, FSH, and luteinizing hormone, LH. This one's my favorite. This was the 17th grade reading level one from Medline Plus on dermatomyositis. Dermatomyositis is one of a group of muscle diseases known as the inflammatory myopathies, which are characterized by chronic muscle inflammation accompanied by muscle weakness. So just in terms of vocabulary and sentence construction, these are really complicated, and there's no reason that a patient, an average patient, would require that level of detail or that level of complexity in an educational handout. We had several limitations. Our sample may not be representative of all patient education materials. We used 1 electronic health records. We used 3 separate databases. And also, readability is not an amazing measure of how comprehensible something is necessarily. It's generally thought to account for somewhere between 50 to 84% of the variance in text difficulty or comprehensibility of a text. They don't account for things like layout, visual aids, and cultural tailoring, which have all been shown to affect how well a patient's able to understand information that you present to them. So we feel that readability, while being necessary, is not sufficient to ensure comprehensibility of these documents. This is the first study to assess the readability of patient education materials that are supplied through any electronic health records companies or the National Library of Medicine. Generally, these studies are done in small sort of subspecialty populations of materials. So places like orthopedics, ophthalmology, palliative care, they look at sort of their materials, but there have been very few studies that look at general materials that are found on the internet. And given health literacy's impact on our healthcare system, it's really important that EHR vendors and the National Library of Medicine provide materials that are going to be designed for comprehension by patients of all levels of health literacy. And we hope that this evidence will sort of support advocates for PEM reform. One thing that I should mention is that Up to Date, while I was writing this up, came out with a for patients section of their website, and that's something that's used really widely, and they do a really excellent job. The information is accurate. It's written at about a 6th grade level, so this is getting more attention, and people are sort of starting to pick up on this being important. Some suggestions for future research in this area. We really don't have a lot of information about whether or not having readable education materials influences health outcomes. So it's possible that having readable materials and having people understand them won't actually change disease outcomes. And if that's the case, then my research and all this other research would be pointless. But it would be good to see if long-term health outcomes are affected by this. And also, there are a lot of other strategies that can be used for educating patients with low health literacy, especially patients who maybe can't read at all. Visual processes, animated educational materials, interactive materials online, those are sort of coming to the fore a little bit more, and it would be good to see whether or not those are having an impact. So I just want to thank my wonderful mentors, Dr. Gliato and Dr. Karani, and my co-authors, Nora Seeger, who's doing her residency now in primary care from Mount Sinai, Rob Fowler, who really helped me with the statistical analysis of these. Seth Zimmerman did some of the computer programming that helped us speed along the readability calculations, and Dr. Fetterman helped with sort of study design and with the writing process. So I'll take questions if people have them.